So this is Waheed Karzai. Today we are presenting EACTA Thoracic Webinar, Recent Advances in Lung Isolation Techniques. We will acquaint you with common methods which are used successfully in our practice in large thoracic centers. We will present. We will also update you on new developments in this area. By the end of the webinar, you'll be able to define indications and relative contraindications on using double lumen tubes or bronchial blockers. We will show you how to integrate video-assisted intubation and video-assisted lung isolation techniques in your practice. We will show you how to make appropriate decisions regarding lung isolation and one lung ventilation with anticipated or unanticipated difficult airway, and we'll discuss airway management in very special case of lung transplantation. As we're talking about airway management, we will not only have a theoretical discussion, we will provide you with practical advice on how you can integrate this in your daily practice.
So indeed, we are proceeding with Professor Waheed Karzai, our moderator for the next presentation, and he is Professor of Anaesthesiology at the University of Jena, Head of Department of the Zentralklinik in Bad Berka in Germany, with major interest in thoracic anesthesia, airway management, ventilation, perioperative risk stratification, and general quality of care. And his talk today is on the important topic of approaches for lung isolation in the patients with the potential difficult airway. Waheed, we are all looking forward to your
Thank you very much, Nandi. Much has been, of course, said about these things, lung isolation, patients with difficult airway, but let's go into this. Way of introduction, I like to talk about objectives of airway management thoracic anesthesia. We have the objective 1, which is lung isolation. That means you isolate a lung such that ventilation remains possible and soilage of healthy lung is prevented. The objective number 2 is lung collapse. That means separate lungs so that one lung collapse can occur and the surgeon has good exposure. Now, when lung isolation is the issue, then it's almost impossible to use anything but a DLT. Of course, you saw in the last talk, you can use an easy blocker in some cases, but that's not something you plan. That's something which comes about, and then when you have an easy blocker, it's a blessing to have it, and then you can use it to. But otherwise, when you plan it, you use a double lumen tube. So if you have bleeding inside a lung, then you use a double lumen tube. Otherwise, you'll contaminate the other lung and have problems with it. If you have an infection, you might also use double lumen tube, because when this goes to the other side and you ventilate the lung, then you will ventilate an infection to the other lung, and at the side and you ventilate the lung, then you will ventilate an infection to the other lung, and it will lead to pneumonia you can't cure. Or if you have a bronchial pleural fistula, that will be a problem. Or if you have airway injuries. So for all these reasons, you need to isolate the lung to be able to ventilate the lung and such, and to avoid spillage of pus or blood into the dependent lung. So when lung isolation is an issue, and that is the case usually in major lung surgery, you might have bleeding in interbronchial, double lumen tube is certainly the best choice. However, when you only need lung collapse, and this is the case in a lot of small-scale lung surgery we do every day, you can use any method of lung separation. You can use a double lumen tube, you can use a bronchial blocker, you can use a univent tube if you like. The choice may depend on costs, expertise, and patient issues. For example, patients who are afraid of damaging their vocal cords, you might use a single lumen tube with a bronchial blocker rather than a DLT. And of course, a very major issue is the difficult airway. So difficult airway is also an issue where you can use an alternative to a DLT. So when lung collapse is the only issue, DLT or bronchial blockers, you can use the bronchial blockers you showed us. For example, we use Fuji Univent bronchial blockers, which is very easy to use. But I also use an ARNT blocker, which is somehow softer, and in some patients I use this, and in some patients I use the Univent. But you can use any of the other types of blockers. We saw some comparisons of DOT and bronchial blockers. Lung isolation, you have a better chance of isolating the lung with a double lumen tube than you have with a bronchial blocker. Inducing lung collapses a bit easier with the double lumen tube, but especially when during the operation the surgeon asks you to inflate and deflate the operated lung, then the double lumen tube is a more versatile tool. Suctioning the non-ventilated lung, for example, if it bleeds or you have pus or something, then of course a double lumen tube is better. Unfortunately, double lumen tube also has the potential for major airway injury, as Mert showed. And if you want to apply oxygen to the non-ventilated lung, the double lumen tube is somewhat better than a bronchial blocker. Adequacy for difficult airway, that's the domain of the bronchial blocker, and that's what we are going to talk about right now. The price is also an issue, but not in my talk now. So when we are talking about now difficult airway in thoracic surgery after this introduction, we have to talk about what is special about difficult airway management in thoracic surgery. We are going to talk about anticipated difficult airway in thoracic surgery, some general issues and options, and anticipated difficult airway in the setting of tracheostomy, and of course about unanticipated difficult airway in options and solutions. So what's special about airway assessment for thoracic surgery? Of course, you have to do the usual airway assessment you do in every patient. That means you use multiple items to assess the airway: interincisor gap, Mallampati scores, cervical spine mobility, theoremental distance. All you can use. I use all of them. I don't use a score. I don't score it. I just use all of them to see how difficult is the airway going to be. But then you have some special issues in thoracic anesthesia, especially when you're using a double lumen tube or such. This makes airway management more difficult because it's a very bulky and stiff tube, so that's one problem. Then you might have tracheal and bronchial pathologies, and that needs special attention. For example, before attempting intubation, you should always survey thoracic CAT scans. This should be one of the first things you do, because you might have a problem, for example, in the left main stem, like in this patient, which will make it very difficult to use a left DOT and proceed with it, because you will have some bleeding and some other problems if you're not cautious. So it's very important to survey thoracic CAT scans, not to miss pathologies like this. Or for example, if you have a problem like this, that you have a tumor which has produced stenosis in the trachea, you have to know that, because you can just proceed and push the tube inside the trachea which can't contain it. Very seldom, but there are patients who have very large airways, and then you'll have, even with the largest double lumen tube, you'll have a problem in getting a seal, even when you put a lot of air in the cuff. You'll still not get any seal, so you have to see how you're going to go about this airway. And this is something Matt also showed. If you have a bend in your trachea, you have to know that beforehand, so you can guide your tube with a bronchoscope so that you won't have any airway injury in these parts of the trachea. So it's very important to survey thoracic CAT scans, and it's very important to read bronchoscopy findings. Many patients already have had a bronchoscopy, and you can read there if there was any problem inside the trachea and the main stem bronchi. Of course, for all difficult airways, and especially in thoracic surgery, in thoracic anesthesia, the minute you think that this is going to be a difficult airway, or it is a difficult airway, have a second anesthesiologist present to assist you. Have at least one well-versed nurse present to assist you, someone who knows that, something about airway management in thoracic anesthesia. Have a difficult airway trolley with all the necessary instruments available brought to the theater end. Then you also have to check that the things you need is actually available. Inform the team on what your plans are and what their role in it is, so that things could go smoothly, and that will facilitate the whole process. And of course, you have to keep in mind that oxygenation and patient safety remains the first priority. So when you have a difficult, anticipated difficult airway, the airway might be very difficult airway, and it might require fiber optic intubation. So in scenario 1, when you only have lung collapses required, the best option is to intubate fiber optic intubation with a single lumen tube and then use a bronchial blocker. That's the best option. I usually prefer to use a size 8 single lumen tube for this purpose, to have enough space for the bronchial blocker, which I'm going to use, and the bronchoscope I'm going to use beside each other. So I use a size 8. You might also use a size 9, but that might that is something we don't much use in my clinical setting. When you're using a smaller tube, check beforehand that the bronchoscope you're using would pass with ease beside the bronchial blocker you're using in the single lumen tube, so you won't get any surprises. Now, if you still have this very difficult airway requiring awake fiber optic intubation, but you need lung isolation, then what I do is primary intubation with a single lumen tube and replace the single lumen tube with a DLT. I replacement only when unavoidable. For most cases, it suffices to have a bronchial blocker. But if there's no way out, then you secure the airway with a single lumen tube, and then you have to reassess if in your practice and setting it's manageable. And if you think it's manageable in your practice and setting, then use an airway exchange catheter of appropriate size and length, usually more than 81 to 85 centimeters, to replace a single lumen tube with DLT, and provide for oxygenation during the procedure if needed. And before you start, instruct the team on plan A. What are you up to? How are you going to make this exchange? And B, what are you going to do if it fails? So, which airway exchange catheter do I use? I use the Cook soft tip airway exchange catheter. You see this tip is very soft, so it doesn't make any injury when you push it inside the bronchial system, and it also allows oxygenation through this port. So it's a very versatile, and you can see that it's 100 centimeters long, so it's very easy to exchange the single lumen tube with a double lumen tube. And it comes in 2 sizes, 11 and 14 French. That means you can use it with the 11 size with smaller double lumen tubes, for example, a 35 size double lumen tube. When I push in the double lumen tube, I use video laryngoscopy to see exactly what I'm doing, and that facilitates the DLT passage through the vocal cords. Which size airway exchange catheter for which size DLT? There's a very nice publication in Minerva Anaesthesiologica, and there you can read which sizes you can use. You can see that the 14 size you can use until size 37, and size 11 you can use for size 35. So that's a good guide to just be able to assess which size you need for the exchange. What about anticipated difficult airway in patients with tracheostomy? Now, there are 2 types of tracheostomies. Now, I don't know about other countries. In Germany, surgical tracheostomies are not a big problem. Why? Because they make a tracheal window, and this is secured to the skin surface. So that means removing and reinserting the tracheostomy tube is easy at all times. So, but you have to check with your surgeon if your surgeon at your setting do the same thing. So we have now 3 options with this kind of surgical tracheostomy. You keep the tube in place and use a bronchial blocker. That is still the best option. Even if you can exchange the tube easily, that's still the best thing. If only lung collapse is needed, then I would prefer to use this. You can also remove the tracheostomy tube and intubate orally with a DLT, and you have to advance the tube with some caution, maybe using a fiber bronchoscope so that at the site where the tracheostomy is done, you don't make some injury. Or you can remove the tracheostomy tube and intubate through the tracheostoma with the DLT. Now, this is something I would rather not do. I would rather do either this with a bronchial blocker, or if I think that's not enough, then I would use intubate orally with a DLT. Now, percutaneous tracheostomies, as done in the ICU, are very problematic, especially in the first 2 or 3 weeks after the procedure. It depends on how the patient, if a patient has a thick neck or a slender neck. So if a tracheostomy tube is removed, the tracheostoma will not remain open. Even not within minutes, the tissue layers will just shift and close it, and reinserting a tube will prove impossible. So it's therefore advisable not to remove the tracheostomy tube if you don't need to. Use rather a bronchial blocker in this setting. So, best option, keep tube in place and insert a bronchial blocker through the tracheostomy tube. Which bronchial blocker? Now there are some studies which show that the ARNT and CORN blockers are more flexible and they're easier to manipulate in the tracheostomy tube, because the tracheostomy tube has a 90-degree bend, and if a bronchial blocker is a bit stiff, it might you might have trouble pushing it in. So these are the ones which have which I have used the ARNT blocker, and it's rather easy to pass it through a tracheostomy tube. So these are the solutions in different publications. You can see that this is a short double lumen tube used, and this is these are also late tracheostomies. That means if you pull out the tube, it will still remain open. And this is also a late tracheostomy. They have used a single lumen tube with a bronchial blocker, and this is also a single lumen. The bronchial blocker has been extra luminally. As you can see, it's not inside the tube, it's outside. And this is inside the tube. As you can see, this is an ARNT bronchial blocker inside the tube, and here's the tracheostoma. This is the mouth of the patient. So there are some solutions in the literature. Other people have used it, so these are all possibilities. But I still believe that the best and easiest possibility is to use a bronchial blocker. What's the